So again, welcome. My name is Jaimee Arnoff. I'm with the Community Technical Assistance Center at NYU's McSilver Institute for Poverty Policy and Research. And I would like to welcome you to today's mental health moment. Our mental health moments are a series of educational offerings that we have where we gain insights from speakers with expertise on critical issues surrounding the child and adolescent behavioral health field. Today, we are very happy to have Dr. Jaimee Arnoff for a conversation about creating culturally responsive care for deaf and hard of hearing youth. So before I get started, I just want to see a couple of things that have been put into the chat box. So we have a good number of folks who are currently working with deaf and hard of hearing children and their families. The inclusion of families is great here. Let's see, gain knowledge about the mental health to better help and understand families we work with. Amazing, thank you so much. Although this offering is titled for deaf and hard of hearing youth, how to support them, clearly we are highlighting the fact that it is a family affair, right? So again, thank you so much everyone for joining us. Before we get started, I do want to just provide a little bit of level setting information. This is clearly not my area of expertise, but again, just so that we're all on the same page, do want to highlight that data from 3 years ago indicates that over 6,000 infants born in the US were identified to be deaf or hard of hearing based on a universal newborn hearing screening. And we know that as a child grows from data as well, that they have a higher risk for mental health challenges, including anxiety and depression compared to their hearing peers. So really just taken together, supporting deaf and hard of hearing children is critical in order to really reduce the potential negative impact on their mental health and overall well-being. And with that, I do want to turn it over to our amazing panelists for today. Dr. Jaimee Arnoff, who is a licensed clinical psychologist specializing with teens and youth adults, including those in the deaf community. So Jaimee, welcome. Thank you so much. I'm wondering if you could just share a little bit about yourself. And I know that there's certainly, given your expertise, a little bit more of level setting information that you want to share with us. So I'm going to turn it over to you.
Thank you so much for having me. Hi, everybody. I'm Dr. Jaimee Arnoff. I am currently in Beacon, New York, which is in the Dutchess County. I grew up in the Hudson Valley area here and had some family friends that had deaf children that I spent weeks with during the summer, especially Sunday family dinners. All of the children in my family went to sign language camp so that communication could be open and accessible from the moment those families sort of joined our family. And so every summer I spent a couple of months at Ketchum High School, which no longer runs the program, but did have an American Sign Language camp. So I had a real foundation for American Sign Language. I continued being a camper at that camp and then eventually a counselor at that camp through high school. It was not a language offered at my high school. I took Spanish, but I did decide to pursue deaf studies at Boston University as well as psychology for undergrad. And then I attended Gallaudet University in Washington, D.C., which is predominantly deaf and hard of hearing students undergraduate. And then depending on the program and the cohort and the year, can be a majority deaf and hard of hearing for graduate school programs, but also for hearing individuals that are interested in, learning more about the deaf community, deaf culture, and working with those individuals. So that led me to have a lot of opportunities, fully immersing myself in the language, becoming fluent in American Sign Language. I had a lot of opportunities to work in deaf schools, do research regarding access, especially with transportation in Washington, D.C. A lot of research, my dissertation was on the relationship and attachment development between hearing mothers and their deaf children. So yeah, I just have a lot of different experiences working in clinical settings, providing culturally affirmative care to deaf and hard of hearing children and their families. And I'm just happy to talk about it with all of you today.
Great. Thank you so much, Jaimee. Really looking forward to this conversation. So I don't know if you want to talk a little bit, again, just for level setting about almost sort of the shift in frameworks, right? Moving from one model to another.
Yeah. So yeah, we think about it sort of in two camps, a medical model and a cultural model. So with the medical model, they might classify it as like a hearing loss as a disability, a pathology, something that needs to be fixed, something that needs to be cured. And contrary to that model, individuals within the deaf community don't consider their deafness to be a disability or something that needs to be fixed or cured. Rather, they recognize these individuals as members of a cultural and linguistic minority. There is encouragement of the development of all communication modes. So that includes speech, but it's not limited to speech, and views sign language as equal to spoken language. So I think we can talk a little bit, you'll notice on the first line that the D in deaf community is capitalized. And so the next slide, we'll talk a little bit about language before we kind of get into the conversation. So it is really important when you're thinking about how to discuss language with clients, but also if you are, referring to them as an individual with a hearing difference. Some people even feel that hearing loss indicates some sort of loss of capacity or capability. So sometimes we'll use hearing difference, but you might be familiar with the term hearing impaired. That term tends to be unpopular due to the subtle undertones that hearing difference impacts capability. So if you see someone, identify themselves, or whether that's in conversation or in an article or in a book, as deaf with a lowercase d, that's simply referring to an audiological condition characterized by a lack of hearing. But a capital D values deafness as an essential element of identity. So the capitalization is an affirmation of culture, identifying as a member of the deaf community, which again is a cultural and linguistic minority. So I think that should hopefully clear up some differences that you might see in some of the resources we provide when there's a differentiation between a lowercase d and a capital D. It's not a typo, it's on purpose.
Great. Yeah. So, you know what? I really do appreciate that, Jaimee, because as we were preparing for this, right, I did say, hey, can you give me a description of the announcement? And as I'm reading through it, because I don't have that knowledge base and that experience, I had actually tagged and said, oh, wait a minute, I think there's a typo here because I see the lowercase here and the capitalization here, and then it's not consistent, right? So from my perspective, it was, we need the consistency. And then when we started talking, I was like, oh, okay. So it was intentional, and there's a reasoning for that, and a very powerful reason behind that. So I really do appreciate you sharing that now.
Yeah, absolutely. It could come in as early as a client inquiry, where someone is identifying themselves as, hi, I am a this age deaf individual, capital D deaf, and they're providing context already for you just in how they are describing themselves. So it's something just worth noting.
Yeah, absolutely. And I do see one of the comments coming in, right, that I had no idea that the capitalization had a meaning behind it, that it was significant. So thank you so much. And I think as you were talking to, before we really sort of get at it sort of from the beginning, right, in terms of how families, what are next steps for families when they're first involved, as you were doing that introduction, what also stood out to me was sort of the conversations that are being had around identity first language and person first language too, right? So being mindful and aware of how a person is introducing themselves or what they're rating, or like what message that conveys before you even meet someone. So I do really appreciate that. Yeah, thanks. So I guess, yeah, if we can kind of go back to the beginning, right? We are looking to see how do we create culturally affirming practice, but if, as folks were mentioning and identifying themselves, I'm working with this child and their family. I'm working with this family. I'm joining to really figure out how to support this child, or I have a family member myself who is also part of the deaf community. If we can take a little step back and maybe think about what are some of those next steps when a family is informed, when a family finds out that their infant has been identified as deaf or hard of hearing. Wonder if you can share a little bit of your thoughts around that.
Absolutely. I typically, at this point, state by state, the infant will have a universal infant hearing screening while they're in the hospital, and that may identify some hearing loss, some hearing difference, and there is sort of like a well-known discussion within the deaf community that as deaf caregivers, they might have a child that fails the hearing screening. So a nurse or a doctor or some provider might come in and look kind of sad and say, "I'm so sorry, the baby failed their hearing screening." But they'll sort of discuss that to normalize it, but also throw a party for passing the deaf test. And again, like emphasizing that it's not a deficit, it's not something that needs to be fixed or cured. It's a welcoming into this amazing cultural community. And but for hearing families who may not have any exposure to deafness, to providers that might be assessing for that hearing loss, that hearing difference, like audiologists, speech therapists, educators, deaf adults in general. It can be really overwhelming, confusing. There might be a push for speech only approaches. Um, there might not be any advocacy for American Sign Language or exposure to sign language early on, and getting those conflicting messages can lead to sort of decision paralysis, guilt, and sometimes delayed action just because they're not really sure where to go, who to listen to. And then there's the psychological impact of having someone bring your infant to you and tell you immediately that they failed a test. There might be some grief, not because of the child themselves, but just their expectations of parenting and the attachment between themselves and their children is different than what they expected. That was sort of the main topic of my dissertation, exploring maternal representations, which is the representation or expectation that these parents had of themselves as parents, of their children on their own, and of the dynamic between the two of them, and how that sort of impacts attachment. Um, and grieving the loss of what a hearing child they had thought of, and feel anxious maybe about their ability to connect with and advocate for their kiddo. So that can be really hard, and that's where early intervention comes in. And a lot of us who work within the community, believe and advocate for early access to American Sign Language because we believe it strengthens not only language development, but attachment between caregiver and child. Also, setting a model for attachment and connection to peers and other individuals in their life. It can be a long lasting impact to have disruptive attachment. And that's not at all due to a lack of love between these caregivers and their children, just a lack of access to emotional and relational cues that come through with this language.
And I appreciate you starting off really focusing on the adults, both within the medical field of their language use too, right? How you also said, well, your child or the baby has quote unquote failed, as you use the air quotes, right? They failed this, and what that conveys to those parents. But at the same time, also in terms of the adults, for the parents, caregivers, normalizing those feelings too, right? Like we need to process that, as you said, sort of there is this potentially like grieving process because this isn't how I imagined. I just now need to reimagine things, right? And there's support out there, right? And that's what we're really trying to highlight, but not just for the caregivers or the families, but also I think those that are first conveying that message or giving that parent, those parents, the information of, okay, this is where your baby is at, right? And really just again highlighting the vulnerability of hearing that, but normalizing those feelings so that we can process. And then where do you go for support for that? Thank you so much. So now that a family of parents might have that information, how might communication differences between the parent and the child impact their development, right? So you talked a little bit about sort of maybe expectations for that relationship development, that emotional connection, but how might those communication differences really impact as very early on?
Yeah, I mean, delayed language development caused by a lack of or even limited access to spoken language, and potentially a withholding of, or just not, even if it's intentional, just a lack of exposure to other deaf individuals who are communicating using American Sign Language has implications for communication development, cognitive ability, behavior in general, and overall mental health. There's stories in some of the books and resources that we'll talk about at the end. Again, sort of well known and common discussion within the community of children who were born deaf or hard of hearing, not realizing that they would grow into adulthood because they never had access to or connection or the opportunity to meet and be around deaf or hard of hearing adults. They were only surrounded by other hearing peers, other hearing adults. Approximately 95% of deaf children are born to hearing parents. Those parents maybe have little, if any, knowledge to American Sign Language. So that's a big push with early intervention to expose these families in general, not just the children, but the parents as they potentially are learning American Sign Language themselves for the very first time. It could be a together activity that they're doing. To have exposure to deaf mentors, to deaf adults, to deaf educators, so that they can see that they can, develop into these fully functioning, healthy, successful, happy adults. And then when you think about as the children get older and from their perspective, we have to consider the physical and mental exhaustion of trying to lip read if there's not verbal communication or nonverbal communication being used in the home. Lip reading just in an effort to participate or be included in conversations. So that's where, again, emphasizing the importance of at least learning and providing some exposure to American Sign Language in the home is going to be really helpful, and providing caregivers for resources for quality ASL classes. So there's a push for attendance of classes led by deaf individuals who, American Sign Language is their first primary and preferred mode of communication, rather than, just finding a class that is taught by someone who maybe doesn't have the lived experience that a deaf or hard of hearing individual in the community does.
Yeah. I think we primarily within the mental health field, the behavioral field, are so aware of the importance of representation, right?
Yeah.
And coming together with different identities and the lived experience of that. And when we talk about being culturally responsive and providing culturally affirming care, there are some groups and communities that really come to our head, to our minds, right? But unfortunately, it seems that the deaf community sometimes is left out of those conversations. So as you were speaking to, right, the importance of representation, not just for that young child to see I can develop into a successful, happy adult who can do anything and everything. I just might have to do it a little bit differently, or I need, different support, but I can do it, right? So that representation there, but also those resources for those parents is how do you also connect parents to folks to really support them as well. But yeah, those are some of the things, the representation and the lived experience as well, so that there is an authentic self that's coming through. So yeah, thank you so much. So appreciate that. So wondering it from there, you talked a little bit about the identity of a person of a deaf and hard of hearing community, right? So what is it a little bit more that you feel we might need to understand as mental health providers about the identity development within deaf and hard of hearing children with their hearing caregivers, with their hearing family members? Anything else that really highlights or that stands out around really understanding the identity development on their end?
Yeah, I think just to sort of piggyback on what you just wrapped up with, that developing sense of self, that developing sense of self-worth, those deaf and hard of hearing youth raised by these hearing individuals may not have had that exposure until adolescence and adulthood, and that delayed access, removes access to role models who affirm their identity, who affirm their preferred mode of communication, and can sort of model some of those things that might have to be done a little bit differently, but still, demonstrate fully capable human beings. And then, as they get older and they're developing into their own individuals with their own sense of self, being mindful of the pressure and attempts to potentially assimilate or acculturate with the mainstream population, which would be considered, hearing individuals, English speaking individuals, and as some report, especially hard of hearing individuals, a feeling of being between worlds. So not
Mhm.
really fully accepted in either hearing world or deaf and hard of hearing world. And that's case by case basis based on their parents' hearing status, whether there's other deaf family members, in their entire system, what their exposure has been like to other deaf individuals. But, having to go to school where they might be the only deaf or hard of hearing student in their class, in their whole school, um, how that develops interpersonally and impacts them and their identity as they're, deciding who they want to be and what they want to do.
Yeah. It's so interesting to hear you speak about that, right? Because I think we can take some of the words that you're using or the adjectives and really apply to also other identities where if
Yeah.
we were talking about that, it would absolutely click, right? So even the maybe I don't feel like I belong in this um sort of social identity, or I'm not perceived to be part of that, and passing as such, whether we're talking about folks in the LGBT community or biracial or multiracial individuals, right? I'm not accepted by one, I'm not accepted by the other. I might be the only person who appears or is presenting or identifies as, and that I think would immediately click for us. But again, we may not have the exposure, unfortunately, to be working with deaf and hard of hearing, kiddos and families per se. So I really do appreciate you bringing that up front. And I do see a couple of questions coming in, so we'll definitely return to some of those later on. But again, as we're talking sort of that family dynamic, wondering if there are any differences with deaf or hard of hearing children who are born to deaf caregivers, because I think the prevalence is low on that, and I think is what you mentioned earlier on, right?
Yeah. Again, 95% of deaf and hard of hearing kids are born to hearing parents. But when they are born into a deaf family, into deaf culture, deaf relatives, they have this affirmation from birth that sort of speaks to their sense of self worth, framing deafness as normal, as natural, something as small as throwing a party for passing the deaf test when they're infants. Just it's not something to be fixed or to overcome. And that again leads to ease with interpersonal effectiveness, not just with their parents, but also with peers as they get older. They have this feeling of connectedness, they have this feeling of belonging. And so they're not as likely to sort of compensate or play down things that might help promote their accessibility or their comfort level in a situation so that they can sort of appear to blend in more with the mainstream.
Appreciate that. So folks on the call today are one way or another helping to support children and families within behavioral health fields, right? So we know that we are in the midst of a youth mental health crisis. We continue to be so. We have so in, for the last couple of years, which is unfortunate. But given your expertise, I'm wondering if you can speak to deaf and hard of hearing youth who might be facing some of higher risk for some mental health challenges compared to their hearing peers. And if you can speak a little bit about what contributes to that, would be great to hear from you.
Yeah, when we think about that medical model, from birth, not just for the children, but the parents who are having to make these decisions quite quickly about how these children are being raised, what early interventions, if any, assistive devices like hearing aids or cochlear implants are involved. Do they go to speech therapy? Where do they go to school? If deafness is framed implicitly or explicitly as a problem to be fixed, then that might lead to some internalized autism, which is just the belief that hearing is superior to deafness, that spoken English is superior to American Sign Language. And that's going to contribute to shame, self doubt, again, that pressure to assimilate into the hearing world, which can come at the cost of their self esteem. So that's going to lead to increased anxiety, increased depression. We might see some behavioral outbursts just because, they're feeling this way and may not have the language to express it, or feel like it's something that can be talked about because perhaps the difference in language being used at the home, or that perspective of sort of the medical model of their deafness versus that cultural model of their deafness.
Yeah, no, it's so interesting to think about how society also plays that larger role, right? In terms of um becoming part of this community that's quote unquote considered the norm, right? Or it's more
Mhm.
prevalent to speak and to hear. And how do you navigate that when, if you identify as, hey, this isn't a deficit, this is part of my community.
Mhm.
Child during those very early years of identity development, social, emotional, relationship identity, how do you do that when you might be one of one or one of very few children that are doing that in those environments, primarily in school? So I guess, just even building up on that a little bit, right? If we have a child who is deaf or hard of hearing and they're maybe again one of one or one of few, what are some things that maybe schools can do or peers can do? You talked a little bit about sort of teachers being support, but given the fact that we know that there might be a higher prevalence for the anxiety, the depression, not because of the innateness of just being deaf or hard of hearing, but of the world and the society that they're a part of, what are some things that other folks might be able to support? And again, I'm thinking more so peers, because there's so much power in peers, primarily earlier on,
Mhm.
right? More about what is your peer communicating than what is an adult, who might be communicating some information.
Sure. I mean, obviously, I would recommend that they read up on the resources. There's so many books written by deaf and hard of hearing individuals with their lived experience, also individuals who have been in the community as hearing individuals, whether they're children of deaf adults or have deaf family members, or just took an American Sign Language class once and fell in love with the community and found their career, working with these individuals. Um, those are the books that I would certainly recommend starting with. There's also, journals and websites of clinicians you can kind of consult with and refer to that we can talk about later if that feels helpful to people. But definitely just learning about the history, about the culture, so that you can ask questions that show that you're engaged and attentive and curious about who they are and their community. Maybe go ahead and take an American Sign Language class, ensuring that if there's an interpreter in the room, that interpreter is certified, being mindful of some of the nuances of having an interpreter in the room. Um, being validating and supportive, that just because they can't hear or aren't using spoken language comfortably doesn't mean that they can't be, star student and do the things that they want to do. Obviously, can invite someone for the students to teach a little bit of sign language, just some basic sign language to encourage communication. Um, Maybe have some nonverbal activities in the classroom. You could, you know, play silly games like charades and things like that without using spoken language, and that could be fun for everybody to participate in. You could do something silly like have people watch a TV show with the volume off so that they have the experience of what it's like to participate in media without sound, and have them, find certain things or pick up on certain emotions or experiences. And then, not necessarily on the teachers or the students themselves, but the caregivers, ensuring that if they are one of one in sort of a mainstream classroom, or don't really have an opportunity to go to deaf events or a deaf school. There's summer camps that are really well known that they can go to and meet children their age that are deaf or hard of hearing. There's deaf events, there's deaf gatherings. So trying to find different ways to connect them to individuals that are just like them, to promote a sense of belonging and kind of boost their self-esteem.
Yeah, no, I thank you so much for that. I think again, that representation, right? When you're talking about events specifically for, or how do we incorporate so that it's not, it's just sort of part of our learning process, right? There's such an emphasis in terms of teaching where how do children learn and how do teens learn most and how can we incorporate these diverse methodologies into our practice? How do
Right.
we also do that and regardless of whether or not there is a child in the classroom or in the community who is deaf or hard of hearing, right? How do we almost start to do that very early on so
Mm-hmm.
that we are exposed to that? So if and when we do, encounter a child or an adult later on in life, right? We're a little bit more exposed to that versus, oh, it's the first time, right? And making those connections. So something like charades, like you mentioned, right, might be a way of doing it without naming it per se.
Exactly.
That's great. Yeah. As opposed to having to do it when you quote unquote need to, right? Build that into the community, build that into society as well.
Right. You don't want that kid to feel sort of like, as a psychologist, what we would identify as like the identified patient or the problem child or the different
Yes.
other. So yeah, just making, there's plenty of icebreakers that can be done without talking and can just be used as gestural and more charade like that you can be creative with. And yeah, it's kind of open and welcoming and allows hearing individuals to sort of have that experience. And I think as psychologists and clinicians, we're sort of expected to ethically hold some multicultural competence. And that's especially if we come into contact with a client that we're seeing that might be different than our typical client to make sure that we're treating them effectively. But I think just in general, as residents of New York, which is a deaf hub, there's pretty large deaf population in New York and New York City, University of Rochester, Rochester Institute of Technology. There's many deaf schools in the area. So it's likely that you're going to come in contact with a client that is they themselves deaf or hard of hearing or has a family member that is deaf or hard of hearing. So I think it's worth, doing the work and attending conversations like this and then continuing on and maybe doing some further research that connects more specifically to the work that you do so that you can be a resource for them if they need it.
Yeah, no, I appreciate the bridging from just sort of our everyday life to the field that we're in. Again, most everyone here is the behavioral health field, right? But even in other practices as well, how do you make that connection, right? And how do you build off of, as opposed to here's when we quote unquote again need to per se. So the title of this talk is how to really build those how to create a culturally responsive care, right?
Mhm.
Culturally affirming as well. So I want to maybe shift to that a little bit. You spoke a little bit about translators per se, but I was also wondering if we can bring in, and right before we went live, we were talking about sort of trauma informed and culturally responsive. And sometimes I feel like they clearly are two separate frameworks, but they feed off of each other. So wondering, yeah, if you can maybe share a little bit more for someone who's seeing a child or an adolescent from the deaf community, what are some additional things that you can do? What does that look like, right? When we say how to create that culturally responsive care, those culturally responsive services. Again, you mentioned a translator. Wondering if there's anything else or anything else that you want to build off of that so that providers can walk away and say, oh, this is something that I might be able to implement because I am working with a child, an adolescent, a family.
Absolutely. And I think, language first. So asking what their preferred mode of communication is, figuring out if that's something that you can provide to them on your own. If not, we can talk much more about incorporating interpreters and creating language access, which is going to be, of course, extremely important when we're talking about behavioral health. But in terms of the trauma and again, case by case basis based on whether the deaf or hard of hearing child is born into a hearing family that has deaf mentorship or exposure to deaf culture in the deaf community, which would include deaf history, like deaf stories, deaf literature, also just educational development, the oralist movement, the history of opinion on assistive devices, on the use of hearing aids, on the use of cochlear implants and how that has and has not contributed to autism, how to recognize autism so that you are not participating in autism. There's such a rich history and culture within that deaf community that's worth learning about, that's worth reading, that is going to be important when you're thinking about their communication, the maybe hyperactivity and hyperattentiveness that they might demonstrate, and the fear of mental health providers in general, the fear of treatment, the fear of inpatient stays, working with law enforcement, just based on the history of the community. And so having knowledge of that history and how that might impact a client, whether again that's implicitly or explicitly, is really going to allow for you to be trauma informed and provide, you know, culturally competent and affirmative care.
As you were speaking, and I know you've mentioned the terminology beforehand, autism.
Yes.
I will say that that is the first time that I've actually come to hear that word, right? And we're used to so many of those different isms. In full transparency, I was like, oh wait, did I mishear? And then as you were speaking, I was able to connect the dots, and yeah, we are familiar with sexism, racism, and just other sorts of phobias, right? But autism is the first time that I've really heard that terminology. So I really appreciate you. Even if we walk away from something, right, it's really that acknowledgement of there is this unfortunate line of thinking that sometimes does become internalized, but also as a society, how are we supporting that without really even maybe recognizing that we're supporting that, right? So I think that's the first step, right? Is recognizing what we're doing, whether intentional or not, and then how can we take a step back and work on that. And I did just see a comment come in around autism. So actually, if you could maybe spend a little bit of time, maybe just talking about the terminology of autism.
Sure, it's AUDISM, coined by Tom Humphreys. Again, speaking to the belief that hearing is superior to deafness. So any recommendation or statement that sort of identifies the hearing impairment, right, as being something that needs to be fixed, needs to be cured, needs to be treated medically with audiology interventions, speech therapy, full immersion in a hearing centered school, hearing centered learning, with spoken language being seen as superior to American Sign Language. And so anything that perpetuates that belief, which to your point, yeah, will likely be internalized by the parents that are receiving these recommendations, but also the children and the youth that are having to participate in, the particular trajectory that these medical providers, and that's, not to say all medical providers and all audiologists are pushing this medical model. That's not true at all. There's some amazing, you know, pediatricians and audiologists and obviously mental health providers that, whether they are members of the deaf community or not, they are, doing the work to be culturally affirming and trauma informed and sort of providing the spectrum of options. So it's not to say that speech therapy wouldn't be beneficial to a child, but it's to say that it's also worth exposing the child to American Sign Language and deaf peers and deaf adults and mentors, and just learning about this, cultural and linguistic minority.
Yeah. It's great to hear that there's a push towards that, because I think frameworks like, family driven or trauma informed and culturally responsive, again, really are so ingrained in the behavioral health field. And then we saw some of that push out to sort of the medical field, right? And now these sort of niche areas, I think it's great. And if there's a way where, how do you still remain and do the work that you're doing, but training for being culturally responsive, right? And working with children and families who are part of the deaf community or trauma informed, things along those lines would just be so enriching, I think. So I guess that's almost like a recommendation for locations and sites and hospitals, right? How do you create the funding, the resources for that?
Mm-hmm.
And one of the comments, and I had seen it in some of the comments come through around, the use of translators. A recent comment just came in, we had to reschedule and push back an appointment because we needed time to find an interpreter. So I know you've mentioned that's a way of, really sort of attending in real time and trying to be inclusive, right? If you don't know American Sign Language or ASL, how can you bring somebody else in? So wondering from your experience of working with this community, how might using an interpreter really impact the treatment in terms of, supporting the child and the family in terms of positive outcomes? But then also, how do you determine who is an appropriate interpreter, and any suggestions for finding them, any suggestions for working with them? Because again, that's some of the comments that just came in, is that we're not aware, like, where do we go to find an interpreter or any other sort of supports?
Definitely. Well, having that open communication access by incorporating an interpreter can certainly strengthen the therapeutic alliance. In research, it's been found to do so. But just by allowing the type and depth of topics to be covered in treatment to be more open and accessible, that information that's then provided to us as, clinicians, impacts the accuracy of our diagnosis, our treatment plans, how we move forward. And when that is all accessible and more open, we're more likely to maintain client retention. If you're looking for an interpreter, it's recommended, if possible, that the interpreter be nationally certified by the National Association of the Deaf, so NAD, and the Registry of Interpreters for the Deaf, so RID. And you can go to the registry's website, and they have a directory where you can find state by state different registered interpreters. So that's, a nationally qualified and certified interpreters. There's also a certifying body, the Certification Commission for Healthcare Interpreters. That's responsible for credentialing healthcare interpreters, which is important because there is language that is specific to working in a clinical setting, working with these populations, talking about these diagnoses, that is maybe a step up or just a step to the side from your typical national certification. And some states actually have their own assessment, interpreter programs that operate totally independently of national certifying bodies. But you can go to the registry and their directory and find providers near you that can either provide in-person or virtual interpreting. And as we think about competence, multicultural competence, having an interpreter in the room is really important, but it shouldn't sort of limit the potential for the clinicians themselves to be learning about ASL, to be taking ASL classes, to understand its own structure and grammar and syntax and differences from English. When you're working with an interpreter, it's really important to speak directly to the client, not to the interpreter. Speak normally and at your typical tone and your typical speech rate. Be mindful of what you're wearing to minimize distractions. I wore this on purpose, a solid color outfit with not too many, pieces of jewelry or really loud, wild nails. And that, again, that's not to generalize. I've certainly had professors and clients and interpreters who've come wearing bold, bright, amazing outfits with fun nails and a bunch of jewelry. But it's just something to be mindful of that can potentially minimize distractions and just make the communication more clear. And then when you're working with the clients, ensuring, because they might have a hesitancy of having an interpreter in the room, an interpreter that might pop up in other areas of their life, talk to them about confidentiality and that these interpreters are bound to confidentiality to sort of calm the nerves, that anything that's going to be talked about in session is going to stay in session, even if they might see you as the provider or the interpreter in other settings, just because of the tight-knit, close nature of those that are in the deaf community and work within the deaf community.
Yeah. So I think that's a great segue, but I do want to acknowledge one of the comments that came through in the chat box. So can you put the links either in the chat or will they be sent out to via email? So I think these were some of the registries that you were talking about. So
Sure.
just for folks, yeah, we will definitely Jaimee and I were talking about maybe creating a tip sheet, sort of a takeaway from the webinar. So certainly encourage you to watch the webinar again, but probably before the end of this month, although we'll have the slides and the recording up on the webpage 2 to 3 days. The tip sheet will take a little bit longer, so that might be like 2 to 3 weeks, but we will include there a section for resources as well. So did want to just name that. But Jaimee, as you were talking about confidentiality and things along those lines, because again, it still is mental health practices, right? There are all these ethical considerations that the field has. Wondering if you can talk a little bit about what are some of those maybe unique or maybe not ethical considerations that might impact folks that are working with folks of the deaf and hard of hearing community.
Yeah, I think the big three for me are multicultural competence that we talked about, confidentiality, which we talked about a little bit, and then multiple relationships. So, if the therapist is hearing and has multiple clients who are affiliated with the deaf community, it is possible that you're treating individuals that know one another. So, I tend not to schedule those clients if they're in person back to back. That way they're not, in the waiting room or passing one another, as they're coming into my office, just to preserve some confidentiality. But also, you might see them around or work with them in different contexts. So there's certainly been interpreters that I know of that serve in a clinical setting, but then also maybe push into a school where a parent that they're working with has a kiddo that is attending an IEP meeting, or maybe it's the kiddo's therapist and then they pop up at school for some reason for an event, or they're on a board together supporting, something within the community. And so those multiple relationships can be complicated and worth just bringing up, putting it on the table, again, speaking to your multicultural competence, that you're aware that this could be something complicated by the dynamics of multiple relationships within this sort of small world. If the clinician is deaf, it might add another layer of complexity in that it might increase the chances that the clinician will have encounters with the clients outside of that clinical setting. So again, just bringing it up, talking about whether or not they have any concerns, how you want to prefer to move forward so that they're comfortable, and that all ethics are being considered and the impact of those ethics are being considered in working with these clients.
Yeah, thank you. Appreciate that. These are some things that we might not even think about, right? And then once, we have a kiddo who is deaf or hard of hearing and their family walks in through our doors. Oh, wait, aside from what are some of the things that I should be, as you mentioned, maybe potentially just be mindful about, right? The colors and who am I talking to, and maybe what are some of the forms that are being asked to be filled out? What are these other things that aren't so sort of tangible, but should definitely be things that we are thinking through. So yeah, thank you for that. I wanted to shift a little bit, and I saw one of the comments come in that I found, so again, everyone, thank you so much for your comments, your questions, feedback. If, you want to add something to the chat box, please do so. But one of the things that stood out to me, obviously we are in the digital age and there's such a focus right now on AI specifically and technology. So thinking about those, one of the questions that came is, can you recommend AI or technology that is successful enough for deaf ASL users and hearing English speakers to use these days?
That's a good question. There's definitely a lot of movement in research, which is building upon. There's gloves that can take information that's coming in through a screen and then like moving the gloves to form American Sign Language or a version of sign language. There definitely, even when I was in college, I worked with the computer sciences and deaf studies program as a research assistant, programming computers to like recognize and break down every aspect of a singular sign, like through the entire lexicon of American signs. And so really training computers and AI to recognize sign language that's being input to them through a camera and sort of projecting back, whether it's in text form or having someone sign back to them. Are any of those things like fully developed and approved at this point? I'm not sure. I think it would be much more recommended, especially if we're talking about clinical work in a clinical setting, having a live interpreter who is catching the nuances, has that added layer of emotion, can sort of check in with the person that they're talking to, have the therapist also interacting with them as sort of fail safes and checks and balances to make sure that the communication is in fact open and accessible. But I do think that there certainly is movement in that domain toward finding additional resources if for some reason you can't find a local registered and certified interpreter, or that option technologically becomes more cost effective. Like, I totally understand all of those factors. And so yeah, something certainly to keep following up with.
Yeah, I think similar to just other sort of forms of technology, right? There are benefits, and then there are, what are some things that we think about? And as you were talking, it also occurred to me, the sort of loss in the facial expression sometimes, right? If it really is just hands or gloves or whatnot that we're trying to recreate, there's a lot of communication that also happens with our expressions that are not going to be captured, are going to be lost per se. So
Yeah.
interesting to think about those things.
Non-verbal communication, like the gestures, is part of the grammatical structure. It's one of the main parameters of American Sign Language. So without that, you are truly missing a large aspect of the language and what the individual is communicating.
Hmm. Okay, interesting. Yeah. And like you said, right, sometimes there are no resources. So how can we do with what we have available, but then also considering and acknowledging, okay, what are we maybe losing along the way? So thank you for that.
Yeah.
Another question that came in, again, I guess around the lines of the under-resourcing for this community, and when we intersect that with maybe other sites or locations that are under-resourced and underfunded per se. So one of the questions was, excuse me, with the limited resources for TOD services, are there programs or agencies that you would recommend families connect to? So TOD, I'm not sure if the person is still here. Aaron, I believe this was you. Is it teaching of the deaf? I'm not sure what the TOD, I tried to quickly look that up, but I guess just overall, any regional or more so statewide services or agencies, organizations that you might be aware of, but also seeing Aaron's comment, yes, teacher of the deaf, thank you. Any programs, agencies, organizations that you might suggest that families connect to when there is an interest and a desire to support children and families, but the resources just are not there?
Yeah, I mean, Gallaudet University and all of the other universities that support the fields that work with this community all have programs and resources that you can connect to. So I think starting at those universities, likely they have resource pages. There's classes that you can potentially take or audit that allow you some insight into how you can better support these students and better support yourself as a TOD. And then that makes me think of resources for clinicians or therapists of deaf and hard of hearing individuals, like the Deaf Counseling Center and National Deaf Therapy, which connect individuals who are seeking therapy services with deaf or ASL fluent providers. And again, that they both also have directories that are state by state that provide options for in-person, for virtual therapy. So if you wanted to see a client and consult with individuals, those are good resources. But also if you wanted to refer out a client, because that's part of our, multicultural competence as well, identifying when we might not be the best fit for a client and that they might just be better suited for a clinician that has more experience, and that might just be a motivation for you to pursue education and training in this field so that you might be better equipped and more confident in your work with deaf hard of hearing individuals in the future. But yeah, there's certainly resources there. And, I find again, because the deaf community is so close and tight knit that once you kind of land on one of these resources, the resources tab is so extensive and supportive and highlighting of all the other resources. Everybody's really trying to build one another up and have that representation because there isn't that much available, relatively speaking. So, I think that those would be good places to start.
Thank you. Yeah. And so, just as you were mentioning, right, recognizing that we may not be that best individual. So there are these directories. So I'm wondering actually if you can type in some of those directories. We're going to include them in the tip sheet, but
Mhm.
I think there wasn't just another comment to see if maybe they can just be included. So I also don't want folks to have to wait for another 2 to 3 weeks or 2 to 3
Yeah.
days to listen to the webinar. But also that last point too that you mentioned, right? That might be the motivation as opposed to not only just recognizing I might not be the best person, so let me refer out, which is great, right? But how can I also maybe help build that gap and take the time to educate myself and become informed, even from, as you were mentioning at the very beginning of this conversation, very early on, just finding out about the history of this community, which again, it's probably not something that all of us or many of us are familiar with. And how do we build from there all the way to these potentially new assistive devices like AI, which again, we're not there, right? But there is so much information. So how do we become educated, informed, curious enough when working with folks? So I think that is great. So I do want to be mindful. I'm mindful of time. So I do want to switch out and just share our last closing slides, primarily around resources, Jaimee, because that has been, again, some of those comments or questions that have come in terms of under-resourcing and whatnot. How can we support each other? And I know you created this list here, so I wanted to turn it over to you.
Yes, absolutely. This is a collection of some of my favorite books, written by some of my professors, some of my peers at this point, which is really amazing. People that really have made their mark on the deaf and hard of hearing community. It's, collection of books I still have in my bookshelf that I reference often and refer parents who might be hearing and have no exposure to deaf or hard of hearing individuals to read up on. But also, as we kind of loop back to this culturally affirming trauma informed therapy, these are the resources that you can go to learn about the history, the culture, the oppression, where autism came from, how it can be perpetuated, and it goes back decades. It's updated more recently. I also, and I can type this into the chat, am constantly checking the Journal of Deaf Studies and Deaf Education. So that would be a great resource as I'm like saying this out loud to the TOD question. Those articles, there's 4 volumes published every year. You can go online and access like almost a full backlog of all of the articles. And that's going to be mostly geared toward deaf education and things that they're learning about in terms of adjusting or accommodating deaf and hard of hearing students. There's also the American Annals of the Deaf. That's also, providing updated research, but you're going to find research that taps into deaf and hard of hearing individuals and their experience over time in articles or journals that are very specific to child development or education, language development, cognition, just based on the specific journal and their focus. But these articles and journal articles in particular are going to be very focused on individuals like those that wrote those books and are kind of working in this field. So those are good recommendations for that.
And we'll highlight some of those in the tip sheet. So thank you so much, Jaimee. As we close out, I apologize, we are a little over time. We have upcoming events. Certainly invite you to visit our website for an event tomorrow, Runaway Homeless Youth, a couple of other events happening next week. I did also want to highlight, we are still ctechny.org. However, later this month, we are switching to McSilver TA. So you will be receiving notices about that, but our old URL, whenever it does switch, will still work. So no need to worry, but did just want to highlight that. And again, similar to the comments that are coming in, I did want to thank Dr. Arnoff for joining us today to really expand what it is to be culturally affirming, culturally responsive, trauma-informed with a community that has been historically marginalized and oppressed, and to this day certainly continues to. So appreciate all of your knowledge, and a big thank you to everyone who joined us today. There is a short feedback form survey. Please take the time to fill that out. Part of this came out of your feedback in terms of communities that we were not really focusing on. So again, thank you all for your past feedback. And again, if you can take the time to fill out the survey, if there's any questions or concerns, please email us at ctech.info@nyu.edu. And with that, I do want to thank you all for joining us and wish you a great rest of your day. Thank you, everyone. Take care.
Thank you.
Thank you.